Welcome back to Clarkston Lighthouse Guidance. I'm Chandler Fleming, owner and lead therapist at Clarkston Lighthouse Counseling. Today we're going to go to section 2 of our program on depression. So, introducing my wife, Victoria, who's also my partner at Clarkston Lighthouse Counseling.
Hey, good morning.
Good morning. How are you doing?
Doing well. How are you?
You know, not too bad. Kind of a heavy topic last time. Talked a lot about depression and suicidality and things along those lines. So, kind of a difficult topic.
It is a difficult topic, and I think it's important for us to recap just a little bit about major depression and what it is, that it is more than just the blues, that it's not just the winter blahs, it's not just, waiting for spring to come, or just a brief time in a person's life. Is something far more serious. So let's just quickly outline what the symptoms are, again for people, and then let's go into the much more hopeful side of the treatment and the fact that it can be overcome.
So we need to remember that depression is quite common. 1 out of 10 women during their lifetime, 1 out of 20 men during their lifetime suffer from major depression.
And that's a pretty high percentage of people. You know, so each of us knows someone.
Yes.
In fact, someone watching this show may be that someone who is wrestling with major depression. So let's look at what are those symptoms from the DSM-5.
Okay. So some of the symptoms out of DSM-5 is that a person is depressed most of the day, almost every day. So it's not coming and going, it's most of the time. And then they have a diminished activity, diminished interest. Nothing really seems to give them pleasure. We use the word anhedonia, which is sort of like the opposite of hedonism. You know, hedonism, you do everything that brings you pleasure. Anhedonia, nothing gives you pleasure. Then we have physical symptoms: weight loss, weight gain, inability to sleep or oversleeping, muscle activity or motor activity, either being way active, kind of agitated, running around, or
retarded.
Retardation. Slower, kind of sluggish, the Eeyore effect. And then really just fatigue and loss of energy in general are more of the physical symptoms of depression.
Right, and then there's also the thinking ones, where it is just the diminished ability to think or concentrate, indecisiveness, feelings of guilt, and just an inappropriate guilt, and then the recurrent thoughts of death. And not just a fear of dying. This is suicidal thoughts, thinking I just can't do it anymore.
Right.
And as you said before, it's significant. It is something that has been impairing a person for a while, and they cannot just shake themselves out of it.
Right, for sure.
So let's look at, all right, so a person now is identified, I am majorly depressed and I need to do something about it. Who are the ones more often to identify with this? What is the prevalence?
You know, I mean, at any given time of people 12 years of age or older, about 7.6% of them suffer from depression. So, and that's in any 2-week period of time. So throughout your 2 weeks, roughly 8% of the people you see are going to be suffering from depression.
That's a lot.
That is a lot.
That's a lot. So it may be someone in a family and a neighbor, someone that you work with. So what are our options? Let's look at the hopeful side.
Sure.
What can be done?
Well, treatment is definitely available. And, you know, there's a big discussion about biological treatment versus more counseling, environmental treatment. So we're going to start off with the biological side of things. The first thing that comes to my mind when we talk about biological treatments is medication, pills. And I think our society, has a hard time with medication. You know, I think back of a lady that I saw pretty early in my career, and it was sort of funny to me because she comes in after starting on medication. I referred her to a psychiatrist, and I was doing counseling with her, and she came in and she says, "I hate your pill." And I said, "Okay, what's going on?" And she said, "Well, it works." And I thought, I don't get it. She goes, "It just shouldn't work that way." With things like diabetes, high blood pressure, even
high cholesterol.
High cholesterol. We're much more willing to take medication, but for some reason we think just because it's our mood that we should just snap out of it.
Now I find that interesting though, because you've actually presented two sides of it. On the one hand, the woman who comes in and says it shouldn't be that easy, it works.
Yes.
So that's the positive is for it, and yet, like you said, there is a resistance. And it seems like a resistance primarily if it is for mental health reasons.
Yes.
But if it is for just a biological, like you said, high blood pressure, diabetes, high cholesterol, people don't even think twice about going to their doctor.
Yeah, a lot of people
being
don't.
prescribed medication. Allergies. Definitely people buy Zyrtec, they buy Claritin, they take their allergy medicine to help alleviate. And yet we've already identified with major depression, there is absolutely a biological side to it.
Yes. And there is a biological side, and biological treatments work well. We know that women are about over twice as likely to be on an antidepressant medication, and women who are a little bit older, 23% of those age 40 to 59 have taken an antidepressant, so it's quite common.
And that would actually kind of play out because we had already identified that 1 out of 10 versus 1 out of 20 men
Yes.
are diagnosed with major depression. So the increase in number of women, or is that even skewed to the fact with people identified that women are still more willing
I
to
think
take
it's probably
the medication?
both. It's interesting because when depression gets into the more severe range, men are just as likely to take an antidepressant. So for mild and moderate depression, women are much more willing to get on board earlier and take their antidepressant. But a man, he's got to be down pretty much, so he's much more likely to wait until it gets really serious and other things are reminding him, hey, this is for real and I need to do something about it.
I can't just shrug it off.
Just can't shrug it off.
Okay, so let's focus on the fact for anyone who may be being resistant to a medication. Let's look at what the medications are. And let's talk about the fact that there are studies that show it does provide significant relief. It is helpful. The brain can get into a rut where it's not utilizing the hormones, the chemicals that are available within the brain the way it used to in a major depressive episode.
Yeah, so starting off, I want to go over selective serotonin reuptake inhibitors. Wow, that's a lot of words. But those are the most commonly used antidepressants. As we know, just by our previous statistics, lots and lots of people have been on an antidepressant or are currently on an antidepressant. So some of the names, just to kind of remind you, would be Prozac, Paxil, Lexapro, Zoloft, Celexa, Luvox. Luvox is less used. I'm not a physician. I've worked in the psychiatric field for a long time, so I maintain a knowledge. And this is kind of just a beginner's course on just different medications. And it's important to know selective serotonin reuptake inhibitors work by they're really focusing on serotonin. That we know that serotonin is the important chemical in the brain. It's the chemical that is most associated with sleep and in mood and in depression and things along those lines. So these medications kind of clog the drains. And by clogging all the drains, it allows the serotonin to build up into the system. So basically, they increase serotonin in your brain.
Okay, so I just want to use that image of the drain. So in a person who is depressed, the brain is actually draining away the serotonin that is needed to improve mood, to improve sleep, to do the things. So what happens when a person takes one of the serotonin reuptake inhibitors is it's a clog over the drain that then forces the brain to take up the serotonin, which then increases the serotonin, which then increases the mood and helps overcome the depression. Okay.
And we have two types of take-up. We have take-up to eliminate from the system, take it out, drain it out, and we have take-up that it kind of uses it and conducts the message. So there's two types of receptor sites that use it and receptor sites that take it and eliminate it from the system.
And I just think it's so important for people to appreciate. So the brain is actually working against you when you're in a major depression. It is taking away something that you need, just like the body is working against you with high blood pressure, with diabetes, with high cholesterol, and you're taking a medication to help you. So it is a viable option.
Yeah, definitely is. Kind of similar to an SSRI is what we call a SNRIs, which are serotonin, norepinephrine, SNRIs, serotonin norepinephrine inhibitors. And they're just like an SSRI, except that it affects also the chemical norepinephrine, affects Prosteq, Cymbalta. They're kind of a newer antidepressant, but they're good, effective. They're a little bit harder to get off of, but there's not a whole lot of discontinuation problems with pure SSRIs, but good, safe medication. And then moving on through the medications, there are some others that are called tricyclic antidepressants. And tricyclic antidepressants have been around for a long time. Most people will recognize it as the name Elavil. very effective. Equally effective is the newer medications in treating depression. The drawback is it has more side effects and different side effects, and has a stronger potential to be lethal in overdose. So some people are hesitant to give a tricyclide antidepressant to somebody who may have suicidal thoughts, because you're giving them a means to their suicidal.
Right.
So.
Okay, and then there's a fourth.
Yeah, there's really just some others. Some people who don't respond to any other antidepressants are put on MAOI inhibitors or MAOIs. They're not used very often because you kind of have to restrict your diet, and if you don't, you can have some blood pressure issues. And then there's some atypical antidepressants, Wellbutrin being probably the most common. Lots of people are on Wellbutrin, and it works a little bit further down the stream, and it actually allows the brain to produce more serotonin in the brain.
And just before we leave that topic, it is important for people to recognize that just like with other medications, you may have to shift and change. You may have to change the dose, you may have to change the particular one, because there's no one size fits all.
Right.
So,
people have a hard time with medication. One of the first questions that I have when I say, hey, I'd like to send you to your family doctor or to your psychiatrist to get on medication, well, how long will I have to take it? And my standard answer in Michigan, you never want to quit your antidepressant during the winter. We know that the depression rates are much, much higher in northern tier states. So in Michigan and Wisconsin and New York, all those northern states, the depression rate is much higher in the winter time. So, but most people, stay on them for a year or two and get off the medication. It's pretty rare for somebody to be on medication longer than a couple of years.
Okay, but I know that there are some other forms of treatment that are very interesting, and I know excite you when you talk about them.
Sure.
So what are some of these other modes of treatment that are more biological?
Right, and this one's, I want to move on to electroconvulsive therapy, ECT. It was known as shock treatments, and it's hard for people to recognize that shock treatments are around today. I actually got in an argument with one of my professors a long time ago about shock treatments, but they're effective. ECT causes the brain to have a seizure, and it kind of resets things. It is the most effective form of treatment. I remember one time getting up early in the morning at like 5 o'clock to go into the hospital to watch somebody receive treatment. And it was kind of boring. The person doesn't flip or flop. They don't really, they're given muscle relaxants and general anesthesia to help them. So, but it's a very effective form of treatment. I know that if antidepressants didn't work for me personally, I would take ECT, just knowing how effective it is if I was suffering from serious depression.
So why the argument with your professor? You said you had an argument with your professor. Was he for it and you were against it, or reverse?
I don't think he had updated information. He kind of went into the world of academics and knew how difficult the treatment was in the past and how sometimes it was used punitively, and they didn't give anesthesia and they didn't give muscle relaxants. So the person would kind of flip and flop over the table. So ECT, a very good form of treatment.
And again, an emphasis on that, it has been modified. It is so different than anything we would have seen in movies, like you said, where it was a shock. It is really a mild form of electricity that is utilized to help reset the brain. And as we've already talked about, the brain can get in a rut. It can get stuck and needs to be jolted back into place. And so ECT can be a very highly effective, studies show it out, to be a highly effective method for treatment.
And the other form of treatment that I wanted to talk about is something called transcranial magnetic stimulation, where they actually take a giant magnet and send magnetic waves right into a very specific part of your brain. And I've only had a few clients receive this treatment, but it's worked very, very well for them. It's kind of on the forefront, but very important. So if you hear about people using magnets to treat the depression, it's for real and it's effective. It's sort of new. So, the results over time are going to tell. There's a lot of new treatments that come in a lot of different areas, and I tend to be the cynic. I'm the one who says, show me over time. But as time goes on, it's really appearing to be quite effective.
And you're definitely talking stronger than the magnets that, say, a child would play with. You're talking stronger than a magnet than people would wear on their wrist. We're talking a scientifically studied, right amount of voltage to
magnetic waves,
magnetic
and very
waves.
specific to a very specific area of the brain.
Right.
So it's kind of fun how they find that specific area, and it's kind of trial and error, and they kind of set that point. So a lot of my clients kind of laugh about going in for their initial evaluation and setting that point. But using magnets to treat depression, it's very effective, and time will tell. So.
But then there's also talking therapy.
Right.
And that's where we offer services, is in talking therapy, and that's a very important part as well.
Oh, for sure. And a lot of people ask, what is it? Is it environment or my biology? We know that people who have parents that are more prone to depression, their kids are. So there's definitely a genetic link. But counseling works, and there's a lot of different kinds of counseling. I like Freudian psychology. I don't use it a whole lot, but I think Freud was a genius. He had a lot of great ideas and really laid down some principles that we have now that are, lay the foundation that by talking to people, there's behavioral, insight-oriented, but probably the most common is, and the most researched, is cognitive behavioral therapy.
And it's one that we use most often. So
Yes.
I do appreciate you mentioning Freud, though, because, there is that thought of having to lay down on the couch, and that's not necessarily the case at all, although if a person wanted to,
Sure.
they'd be welcome to,
I
if
have
they're
some
more
kids come in and
comfortable.
lay down on the couch. I don't know if they're lazy or they want to be Freudian. But,
I don't know if they've heard of Freud. Maybe,
Yeah, I
though.
think they have.
Possibly.
I think we all heard of
yeah,
Freud at some point or another.
But cognitive behavioral therapy is, like you said, a very researched and studied one, and it's one that has great impact on a person, and it's the one where they can start changing some of the thought processes and help challenge how they've been thinking, and start challenging some of the behaviors that may have become entrenched during this major depressive episode, and start impacting their life. And it can be in conjunction with some other modalities. It can be in conjunction with medication.
Yes.
So, but talking therapy is very, very effective. So let's look at that a little more.
Okay, so in cognitive behavioral therapy, we look at perceptions and interpretation of those things. I walk outside and it's 72 degrees and sunny. Is that
Beautiful
a good day?
day.
Well, maybe not. Maybe it's Christmas and I really wanted snow. Or, maybe I have a really bad headache that day and the sun just irritates my eyes. So very few things in this world are black and white in those terms. It's really subject to interpretation. I actually had a kid that I just loved. I loved working with him. He was a great kid in my practice, and he made all A's. And I said, "So, Richard, congratulations, you made all A's." And he goes, "Yeah, that really sucks, doesn't it?" And I thought, "You said A's like in apples, didn't you?"
Wow.
And he said, "Yeah, it just proves what a mess up I am. That by making all A's, he saw that as a really negative thing." And he had a point. He was a high school senior. He made all A's his first semester, and he made a lot of C's and D's. And he realized that he blew a lot of opportunities. So how do you use that? How do we use that, and how do we apply that information? How do we perceive it? So in cognitive therapy, we teach people to look at, what are your negative bias? And what is a way of looking at this to the positive? What are things that you can do about it, and what are things that you can't do about it? We can't change the past, but we can learn from the past and press on to the future.
So even to use that example of the young man who had made all the A's and recognized all the lost opportunity, he now has a choice. He can focus on all the lost opportunities, or he can look and say, okay, so I may have made some mistakes, I may have made some mess, but I'm clearly able. I'm able to make A's, and I'm able to succeed, and springboard, change the focus, change the thinking. And I know that very often when I have someone come in, is that outside perspective.
Yes.
Is that objective outside perspective, and I will sometimes ask a question and you see almost literally that light bulb go on over their head, and they're like, I never thought about it that way.
Sure.
And that's very often all it takes are just some of those questions over time, as we get to know the client and get to ask them some questions where they start thinking differently, and then they start behaving differently.
Oh, for sure. And feeling better. If you believe that everything you do is a mistake, then you feel like a loser. if you recognize, hey, I made some positive improvement, then you can feel better. So.
And I know something else that I've noticed in sessions are when people use very strong negative words.
Yes.
You know, this is terrible, this is awful, this is tragic, this is a huge big deal. And then being able to help them regain some perspective.
Oh yeah.
Ask themselves some questions. What is the actual impact of this? And then follow it through. And then they recognize, oh, okay, so maybe it's not tragic, maybe it's not awful.
Yeah. Developing those scales and using scaling is really, really important. And who do you compare yourself to? You know what, I'm pretty poor if I compare myself to Bill Gates. But if I compare myself to a starving child in Africa, I'm very rich. So, and mentally, where do we compare ourselves is really, really important.
So, and then going back to the majorly depressed person.
Yes.
So what we have found is that the thinking does become negative.
Yes.
It does become hopeless.
Yep.
And so it's helping that person talk through what feels very real.
Yes.
And seems very true, to challenge it, to again, you know, just like medication is trying to increase the serotonin or is increasing the serotonin, we are then helping the person to challenge their thinking, to change their thinking and improve their mood.
And really just to help themselves. You know, and we talked a little bit about that in our earlier show about how much can somebody control. Well, you have to use the power and control that you have. So there are things that people can do. Self-help methods of looking at your diet and exercise. Sleep hygiene, you know, being very, very focused on making sure you go to bed at a decent hour and doing your very, very best. One of the things I like is to teach people about the 1% rule, or what are those small things that rob you of energy. So or it may be a leaky faucet, or you know, forgetting where you leave your keys, and that could be a moment of just frustration throughout your day. Hey, where did I leave my keys? 1% rule says leave your keys in the same spot every day. You have more energy. So it's kind of basic. Learning relaxation techniques and avoiding alcohol and drugs can all be ways of people helping themselves.
Right, because really it's just an hour that we may see someone once a week.
Yes.
So our goal is to gird a person up, to
Yes.
give them a foundation upon which they can build as they go forth.
Right.
And I so appreciate what you were saying about the 1% rule, about taking those extra steps. So through cognitive behavioral therapy, through talk therapy, a person is able to learn skills. To find that self-help, to use a combination, so it may be the biological, the
Yep.
medication,
Yeah.
as well as the counseling, as well as the things they do outside.
Yeah.
A blend, and then major depression does not have to stay.
Right, it doesn't have to
overcome.
stay. And I would strongly urge people to start off, get some counseling. Make a plan. It really saddens me when I hear of people who have been on medication for a long period of time and don't get that added counseling. The two things work good hand in hand, the combination works well. But counseling is very, very effective, and the side effects are very, very low. So work that combination. If you have further questions about our topic, feel free to give us a call at 248-245-1809. Also, check us out on Facebook. You know, we're looking for lots of likes. So go ahead and like us on Facebook, and you know, look at us at Clarkston Lighthouse Guidance. That's our Facebook address. And then also feel free to email us. We'll be glad to reply to your questions. And our email address is guidance@clarkstonlighthousecounseling.com. Thank you very much, and I appreciate you watching our show.
Have a good day.
The views expressed in this show are for general educational purposes only and do not constitute professional advice on any subject matter, nor do they necessarily reflect the views or opinions of its guests or of Independence Television. If mental health assistance is needed, please seek professional licensed treatment.